Where do you see the future of pain management going?
There are a lot of new technologies coming in pain management, including some stimulation, like nerve stimulations.
Yeah.
Nerve stimulators have been around, or like the implanted spinal cord stimulators. Those have been
Right.
around and they are often very good. But I think what's really interesting is this newer generation of temporary stimulators that sometimes will keep pain from becoming more embedded in the nervous system, that we can sometimes reverse, pain that's been going on for a period of time, and it may not always require a permanent implant. I mean, I think that's pretty interesting.
Hi, this is the Care Room with Dr. Cindy. Welcome. It's a space that was created just for you. I'm your host, Dr. Cindy, and this is a chance to get up close and personal with me. We're going to talk about the things in medicine that matter to you. We'll talk about the questions you've been carrying. We're going to have some honest conversations. We're going to hold space for joy, struggles, and everything in between. It's care that goes beyond the exam room. Care you're going to take home with you, whether you're listening while you're driving or you're listening while you're exercising. I promise that it's going to be care that's rooted in truth and a deep commitment to walking with you every step of the way. I'm glad you're here.
Hi, everyone. Welcome to another episode of the Care Room with Dr. Cindy, where we chat with our lovely doctors about the things that, discuss at home and you bring in to us, your doctors. We're hoping that we have some answers for you. Today, I have the lovely Dr. Sarah Merritt with us. She is an anesthesiologist with a background in pain management, and she's here to talk to us about all things with pain and, what we can do to help with that. So before we delve into things, I'll just let Dr. Merritt introduce herself and tell us a bit more about what she does and where she's from. All
Sure.
yours, Dr. Merritt.
Thank you. Yeah, my name is Sarah Merritt. I'm a physician, I'm an anesthesiologist, and I'm board certified actually in three areas: in anesthesia, in pain management, and also in addiction medicine. Because if you do enough pain management, at some point you're going to have
Yes.
some folks who may have an addiction problem.
Yeah.
So I really am pretty deep in that pain management world. At this point, I don't really practice anesthesia. I see patients with acute and chronic pain for the most part. We do have a branch of the practice that's for addiction medicine, but predominantly most of my work is in pain. And we do prescribe also like buprenorphine, whether for pain or for addiction. That's a medication that's been in the news lately.
Right.
So that's part of our practice. We do things like injections and medication management, referrals for physical therapy, et cetera. Because I think, a lot of times patients may not know what to expect from a pain management doctor if they've never seen one before. What would that look like? What does that, care look like?
Sure. Sure. So, Dr. Merritt, how does one become a pain management doctor?
Yeah, I had like a roundabout route. I did not set out to be a pain management doctor. Very early on, I guess I thought I wanted to maybe be a pediatrician because when I was a kid and I first thought about being a doctor, and that was the only kind of doctor
Yeah.
I'd had any contact with. Right? I think that's
I
common
think
for a
a
lot
lot
of
of us.
that. Yeah. Um, and then, yeah, through training, I ended up interested in the OR and like things that were maybe more surgical in nature. And I went as far actually as matching in ENT and did that surgical residency and just found that I wanted to go in a different direction. And I started just with 1 year. And after my surgical internship year, I switched into anesthesia. And really, it was that moment, actually, that switch. And there were a lot of conversations and a lot of soul searching that went into making that switch. But in that moment, I was very fortunately paired with a wonderful mentor, actually, Dr. Pamela Vick, who's a pain management doctor. And at the time, she was like, "You don't know it yet, but you want to be a pain management doctor." And really, what pain management, kind of held for me was a couple of things. One is I enjoy the aspect that, we have clinic visits, but then we also have a procedural component to what we
Right.
do.
Right.
There is the way that I practice, there's balance there. I do both. I'm involved in both. And then also, I think, and this is maybe what I got some from my mentorship with Dr. Vick, was really if you help somebody with a severe pain problem, you've really helped them with what is their worst thing.
I
If
think so.
people are really impaired in terms of pain, it's a huge deal. It impacts every part of their life. And so when we can make that difference, it's really exciting.
It is. It is. And I can't tell you how many patients I see with pain as a primary care doctor. Like
Yeah.
it's one of the things that we tend to deal with, I think at least every day. You
Yeah.
go, yeah, there's at least one patient, that you're trying to figure out, what else can I do? What else
Yeah.
can I do to make things
Well,
better?
and
Yeah.
generally speaking, like pain is the number one reason people seek medical care, right? Like whether it's chest pain that sends you to the ER, or, you've fallen and you have an injured extremity. Pain is a lot of what makes us seek that medical care. And then in some patients, pain becomes a s- ideally pain is a signal of an injury or a problem, but sometimes if the system is not right, if someone's had a severe enough injury that that signal has gone on a long time, then you could have pain signals that just are not really turning off and become kind of pathologic in their own way.
Yeah. Yeah. So, is there a particular age range that you tend to see more pain, a subset of pain patients with?
Hmm.
Yeah.
Yeah, in my practice we have some diversity, I would say, in that respect. And maybe it's like certain groups. For one thing, we have quite a few senior citizens
Right.
because, pain is a normal part of aging, and just, adapting to that. Patients, seniors that like maybe never had a pain problem before may find that they need like a daily medication for pain, or may find that they benefit from injections, things like that they haven't needed in the past. So that is probably a lot of our bread and butter. We have see patients in their 40s, and I think we were talking about this before the show, where there are like adjustments happening in the body, and maybe you're not a senior citizen, but your body is changing, and you're having new problems or new aches and pains.
Right.
And I guess if we were talking about ages too, and this may be a hot topic too in primary care, I actually have a fair number of young patients in my practice that I see because I've developed some expertise in treating patients with Ehlers-Danlos syndrome.
Okay.
And so we see quite a few of those folks. And I write a lot of low dose naltrexone for
Okay.
that younger population with significant chronic pain. Because we don't
It's
normally think of like people under 35 as like you
yeah.
shouldn't have any chronic pain, right? That
Right.
shouldn't be
Right.
a
Right. Did you try Tylenol? Did you try ibuprofen? And then, things escalate from there. So, Dr. Merritt, say I have a young man, he's probably in his 30s.
thing.
He's coming in. I've seen him probably 2 or 3 times. And guys, this is a hypothetical patient. This is not one of my patients in the clinic, but we tend to see patients who can fit some or more of this story. But, he's always letting me know like, "Yeah, doc, I tried the Tylenol. I tried alternating with ibuprofen. I'm using my lidocaine patch. I know, sometimes I have that shooting pain down my leg. You told me, we could start this gabapentin, but it's like I'm taking candy. It's not helping. And, we've bumped up this dose of the gabapentin. What do you recommend we do with a patient like that? And I know you can't really say because,
Yeah, yeah. I mean, I think, and you're kind of describing the history and physical, right? This is the conversation you have with the patient. You get the history of their complaint and what the issues are, and maybe, yeah, taking into account the things that this person's tried. I'd also be interested in like, well, has this person had any imaging? In young people, sometimes we are reluctant to get imaging, on the one hand because and there are some guidelines around it. For instance, like for somebody that comes in with like an acute episode of back pain, and acute being a week or less, something like an MRI is usually not recommended. And the reason is it's just too soon. That it's very common to have an acute or self-limited short episode of back pain, and generally it's not cost effective, it doesn't produce better outcomes, etc. That early on, like for that patient that comes in with acute pain, really the recommendations are for like reassurance and physical therapy. An x-ray might be reasonable just to rule out a fracture. And a lot of times if I'm having that visit, I'm also going to set that expectation with the patient of when we would do an MRI. okay, hey, if you're still dealing with this in a significant way at 4 to 6 weeks, might be a time that that could be considered.
And even
Sometimes if
insurance.
a patient's had a trauma, like an MRI might be appropriate earlier, or
Sure.
if the person has significant weakness, so that might indicate like radiculopathy or a compromised nerve, it could be appropriate to get those studies earlier.
Yeah.
So, I mean, I think, if we're talking about this person who has like what sounds like some sciatic pain down the leg, I mean, you really have to think about what do we think the diagnosis is first. And so
Yeah.
that's why I'm starting with kind of confirming that H&P and thinking about like what imaging, if any, we've had, and based on the time frame it's been going on, like what's appropriate.
And when would you consider like injections, spinal
Yeah.
injection?
Yeah, so I would offer that to patients, usually, and in fact, these days there are even like kind of some insurance guidelines around a lot of these. For that patient with radiating leg pain, like an epidural could be sooner, like depending honestly like how miserable this person is, if they are in a bad way and ready to move forward. I mean, as soon as 4 to 6 weeks can be okay.
Yeah.
Or for instance, I saw a patient today who has had his back pain and leg pain problem on and off probably for 5 years. He's a physician,
Okay.
had never had an MRI,
Okay.
had his partner refer him for an MRI. And sure enough, he has kind of an acute disc situation. And so we talked, and even though like this episode hasn't been that long itself, maybe 3 weeks or so, it's in the context of like a very long time.
Sure.
So certainly like at 3 to 4 weeks with the radicular symptoms and with, likely cause, it could be reasonable.
It could be reasonable. Okay. And that's fair. Yeah. Um, I know that, when we talk about pain management, a lot of us who refer to pain management, we're expecting medications. But are there any like lifestyle changes that you guys recommend as well to help with pain?
Yeah, yeah, I think that's a really interesting question, and I think there's more and more coming out in that regard that absolutely there are lifestyle changes that can help with pain management. And the real limiter as I see it is like, insurance kind of covering the type of visit that's needed and then a patient being willing to engage with it.
Yeah.
You know, I think this is where actually probably the best bang for your buck in the insurance world is physical therapy, maybe, because there is a lot of like lifestyle change that's discussed in good PT. Good physical therapy involves pain education, which includes like not being afraid of moving. And so, like reassuring and educating patients, teaching them ways to move that don't tend to provoke their pain. And so they can find those ways that, again, are not generating fear or that kinesiophobia is the word that they'll use for it sometimes. That, fear of movement that can kind of get people in a limiting, difficult cycle. I mean, so I think that's like a big lifestyle factor is really like moving more as much as possible. I think there are dietary changes that can help with pain. Do I do that a ton in my practice? Not that much because it's difficult. We work in an insurance model, but I absolutely make some referrals to nutrition when people want to. We do have a couple of nutritionists that we work with and that work in an insurance model, in fact, even and with the right diagnoses often are able to do that kind of work. And I
Sure.
think some patients would benefit from weight loss or weight optimization,
Yeah. Yeah.
even as little as like 10 or 20 pounds. I mean, I will tend to tell folks, I mean, and this depends, right? People come in all shapes and sizes, and look like you don't need to look like a bikini model to eliminate your back pain, right? Like that's just not realistic. But on the other hand, if your BMI is 35 or 40, even dropping 5 or 10 pounds, can really be associated with significantly less body fat related inflammation. Muscle is good. Again, like skinny isn't necessarily better, but finding that balance of maybe reducing body fat and preserving, as much muscle as possible.
That's awesome. And I know we tend, even with those, because I see a lot of like knee pain and, the ortho docs, they want them to lose some weight before they do surgery. And then sometimes I have some patients who will say, oh, it actually feels better with just you losing that weight pre-op. So it's amazing. It's amazing what can happen with some weight loss.
That's right. Yeah, and there's really interesting data about some of those new weight loss drugs that because they control inflammation so well, in addition to the weight loss that's associated, I think many patients may, if they're using that as part of a weight loss plan, may also experience pain related benefits from that.
Yeah. Interesting. Isn't that amazing? And
It is.
still learning so much, as time goes on. It's amazing. I'm just
And I
impressed.
think it's a double-edged sword though, because I will say, and I imagine you have this experience in talking to patients. On the other hand, if I do talk to someone who has a high body mass index, on the one hand, like I don't necessarily want to, hey, this is just because you're overweight, right?
Exactly.
Like we don't necessarily want to chalk it all up to that, or hey, you'll feel better if you lose weight and that's all there is to it. That really like a multimodal treatment plan is what's going to be the most effective. So considering physical therapy, injections, medications, et cetera. But part of that, again, lifestyle modification and getting people the most benefit is considering the whole person and making like patient specific recommendations. And in that patient who has a BMI of 40, not much question that some BMI reduction would be likely to help with longevity. Below 25, we don't think there's any benefit for that, right? But at 40 or so, we can probably benefit to unload joints. Really anything above 25, there's an argument you could possibly benefit to unload those joints.
Right. Which brings me to my next question, Dr. Merritt. So, are you ever able to completely get rid of someone's pain? Or are we dealing with, okay, I'm just going to control it. Um, you're going to have to live with pain versus pushing through to
Mhm.
get to this miraculous end.
Yeah, I mean, I think that's so interesting. Very often, and I think that's one of the reasons, frankly, that the way that our specialty talks about itself is pain management, and it's not necessarily the pain elimination clinic or the pain cure clinic. It's
Right.
the pain management clinic, and it's because like there's a lot to it.
Right.
Pain is like we could get kind of deep on it, but it's like a part of the human experience, and um we can hopefully eliminate a lot of pathological pain for patients to help people function better, feel better. I would say that very often we can make pain more livable, and there are times that we are able to limit it or eliminate it entirely. And it really kind of depends on that person's diagnosis. What as far as where we're able to get them to. And I do think patients, expectations can have some to do with it. Certainly I see patients with like more acute injuries where, we may treat them with medication or an injection. And if they're doing pretty well, they may disappear for, months or years at a time from my practice and, reappear, if and when they need treatment. So I think it really depends, but yeah, very often it's a matter of getting things to a more livable place. Yeah, that's what we can almost always have some success at. And
Right.
then sometimes we do even better than that.
Yeah, okay, we'll take that. We'll take
Mhm.
that. So, can you tell us more? Because sometimes pain can keep patients out of work, right? And I'm sure you see a lot of those patients, and they come in, they need time off from work. And what I'm talking about is FMLA. If anyone is not familiar with that, this is like the Family Medical Leave Act, and all of that's associated with that. But can you explain in plain terms like how FMLA works and when pain issues might qualify a patient for that?
Absolutely. Yeah, and as a, I'm a pain doctor and I'm an employer too. So, I've seen this sort of thing also from the employer side, or I think about it, that way too, because, we work with our employees as well, when they need time off for various reasons. So, FMLA is some paperwork that probably you and I fill out. The FMLA Act is like the Family Medical Leave Act and should give people an opportunity to take time off of their job without pay for a period of time. And so not every business has to offer FMLA. So it's usually bigger businesses. I think it's over maybe 50 employees at that point. Businesses are required to offer it. Smaller businesses like mine with fewer than 50 employees, it's frankly more burdensome. And so I think that's the part that as the employee or the person with the issue, just understanding where, what the policies of your employer are obviously is going to be important. But if you have a job that, allows you to take unpaid leave for specific illnesses, I think that can be a totally reasonable thing. In my experience with my patients, I'll have folks probably like two big buckets of ways people need FMLA paperwork. Sometimes it's around some specific diagnoses like headaches, like people with migraines, perhaps, or people who have episodic low back pain or just a pain flare that kind of puts them out, so to speak, kind of not very functional for a couple of
Mhm.
days at a time. And when patients experience pain like that, where really they're either A, going to be like non functional and useless at work, and or they're not going to get better without that rest. Like,
Right.
when
Mm.
my back does this, I need to just be flat for about 24 hours and then I can think about going again. So that's where we, work with patients and can sign off on that type of paperwork. The challenge that we get into is really, what's the right amount? And this is where like I kind of have some, conversations with patients like, hey, I can write that it's okay for you to take a day or two off a week for, you know, every week of the month. But if that's what it is and if that's what you're taking, I don't know if you're going to be in this job for very long, right? It's pretty soon you're going to be not meeting the needs of your job. So,
So,
really it kind of
um,
gets us having those conversations with patients
yeah,
about
sure.
what makes sense, in the big picture for them. Really the other advice I tend to give patients, is a couple things like, bodies in motion, stay in motion. So, continuing to be as active as possible in whatever way. We certainly have patients that at times, get to a point where they feel or, need to go out on disability for a longer period of time. But, also having those frank conversations, hey, that's really not going to support you or your family in the, you know, to a level of income that you're used to from any type of job.
Right.
It's just not going to be the same. So really I feel like some of what we do is like kind of cheerlead people. If with some leave somebody can continue to function, then I think that's a way better situation probably for everybody if a happy medium can be found where with some amount of maybe unpaid leave for a medical issue, somebody can continue to do their job.
Sure. Have you had any patients give pushback or demand, like, that this is what I need, this is what I want, let's do it? Uh, or is it
Really, I mean, I think I just kind of tell them this is what we'll sign, like this is what's within reason to me. And even if we write kind of a generous like amount of time off, usually, your employer, I don't know, I think this is where I shouldn't put on my employment lawyer hat because I'm not an employment lawyer, but I think at some point, like, you know, the job may not be there is all,
right, right.
so but very often, I can at least think of the last couple, and I can think of one patient who mostly works from home but needs to be in the office a couple of days a week. And I feel like we wrote some accommodations around that. And sometimes they'll have even if someone has a productive relationship with their boss,
Sure.
sometimes they'll come to me with like, "Hey, I've talked to my boss already. This is what's okay.
Okay.
If you're okay to sign off on it." I mean, that's like a best case scenario, where they're really kind of handling it. They're having those proactive, like adult conversations of like, "Hey, here's what I think I can do if that works for the company." And then the boss may have to say like, well, if I'm giving you some, different accommodations than other people, you know we need some paperwork from the doctor, we need some, medical reasons of why, if you have different, working terms, and that's maybe more on a, disability accommodation versus FMLA. But again, like in terms of, what's reasonable, and finding hopefully that win-win, really, right? Because I think that's when, Frank, back to like feeling like you've helped somebody,
Right.
that's when we've really, helped somebody,
Right.
especially in today's world with like remote work and ability for certain accommodations, with those patients who are finding ways to function, in a remote or partial remote environment that might have really a lot of difficulty with in-person jobs,
Right.
that we can really feel like we've helped make an impact.
Yeah. Dr. Merritt, have you ever found a patient on the opposite end, someone who is working through, like they're just pushing through pain, pushing through whatever they're suffering through? And have you ever had to counsel them on, probably taking a sick day if needed? Have you
Oh, that's a
seen?
good question. Yeah, I think maybe not exactly. I mean, it's difficult as the pain doctor. I get such a little snapshot, right? Like in the office, I get such a brief snapshot. I do think I will hear that maybe even some from patients if they've had that conversation with their PT, right? Because the physical therapist might be in fact meeting with them more frequently, and might even have a bigger picture of, their functional status and what they are and aren't pushing through even than I do, honestly, just because of the nature and the frequency of the conversations that they have. But yeah, I think absolutely patients need to also like there is a certain amount of listen to your body and find that happy medium. I mean, I think certainly patients that I'm seeing, are coming for some type of help, right? So I mean, there's probably a segment of the population that just isn't coming to the doctor, right? Or I can tell you, I saw a patient today who I know, is working well into her 60s, has actually a pretty physical job that she enjoys and loves and is doing it because she gets like a lot of enjoyment from it. And she's, hardly needed to go to the doctor. But now she has like some pretty significant arthritis and, like needs a little boost to get through. So I think, the way that I interface with those types of patients is, if they get to like I don't know if I exactly want to say a breaking point, but maybe a tipping point, where it's like, okay, now I think I want some assistance with this.
This? Okay. But in special populations, guilty, like us doctors, right? We don't take a day off. You're expected to show up whether you're sick or not because you have to take care of people. And I've worked in the hospital. I've had coworkers, who show up with their back pain and they're just pushing through.
Hmm.
They're tight, whether it's spasming or,
Hmm.
other issues. And it's not that it's, frowned upon to take a sick day, but, sometimes people are counting on you.
Yeah. And I think that's the stress of that is actually what is difficult and possibly destructive, is when you like feel you can't.
Yeah.
I think that is a real problem for doctors. Like kind of some of the advice from the pain management world, frankly, is to like push through a lot of things
Mhm.
because, as a doctor, you're probably aware of this. You can if we see a 40-year-old with back pain and we do an MRI and they have degenerative disc disease, just meaning, they have some premature aging of the discs in the spine. Well, if you took there are some studies where they took 140-year-olds without any back pain and they did the same MRIs, and about 50% of those people with no back pain have the
Sure.
same MRI.
Yeah.
So, like, pain is a feeling. And I think it's back to like, well, so what's the diagnosis? Maybe it kind of depends. I do think that we can push through a lot of things and that there's a negative to like over attending to pain symptoms and over anxiety around pain symptoms.
Mm.
However, totally ignoring yourself and not allowing for self-care, right? Like that's not good either. And so where is this like happy medium?
Sure.
But I do think that, like to your point, thinking about like a clinician, maybe someone who's working in the hospital, who feels like, hey, I can't let my team down. I have to, be at work, like to some degree, like shouldering that burden and like that emotional aspect of it actually colors the pain experience. And so there's a definition of pain that there's this group called the IASP. It's like the kind of the academic body of pain research. And they have this definition that like pain is a sensory and emotional experience, that it's not just the pain sensors going off in your brain, that it is tied in, very closely with our emotions. And it is colored by the emotions in our brains and in our minds and spirits. So I think it's just an important way to think about it
Right.
that it's more than just the fancy word would be nociception, like the pain signal. It's not just that. It's like the sensory and emotional experience. And so that aspect of, feeling like you have to go, feeling like you don't have space. Or for the patient who was, we see a lot of people who've been injured at work. If you're injured at work and you're going back to a job that you don't feel safe, that can be like a not good thing for that emotional side of the pain,
Hmm.
and could be like counterproductive as well. So I think we can't discount that part.
Do you deal with a lot of psychosomatic symptoms in patients, the psych component of things?
I mean, I think we try not to ignore that, we're beings with, feelings. And it's a challenging thing to navigate because there's never a moment that we, can look at that patient and say, hey, your problem is all psychosomatic. It's not really that. What we can do and can say is, hey, you feel whatever you feel. Your pain is real, right? So the way that I've been taught, and I think the way that's most productive to work with patients with pain is to acknowledge like all pain is real, right? Like I can't feel the sensations in your body, right? I can't feel your emotions exactly. We can empathize, etc., but it's just not the same, right? Like we're not in each other's heads. So you have a unique experience, and that the patient, you feel whatever you feel. It's not for me to gaslight you and say you don't have pain or this pain is made up or psychosomatic. But we can acknowledge like this is a signal in the brain.
Right.
There is a signal in the brain that is happening. And there may be peripheral inputs from an injury, from, a back that's had surgery, from a knee that has severe osteoarthritis. But then there are also these patients who maybe don't have a very concerning looking MRI, but they still have back pain. And I guess, the way you can look at that different ways, to me, that just means I wouldn't necessarily tell them, hey, your pain is psychosomatic. It's more like, you know, this is not mechanical back pain, or, we don't have an indication that this is mechanical back pain. This may be one of these things where the nerves are turned on too high, right?
Sure.
That this is an over amplified pain signal. And that's more what we're dealing with. Um,
Yeah.
and, concurrent treatment of anxiety and depression does help patients with significant chronic pain. And so if people have untreated mood disorders, particularly anxiety and depression, that can be helpful.
And we tend to use a lot of the SNRIs, Cymbalta or for both like the mood and, with pain, that pain component, neuropathic pain
Absolutely.
component as well. But Dr. Merritt, for us primary care doctors,
Mhm.
we see a lot of pain patients. Any advice for us? General advice?
I would consider, and maybe I need to like generate a little handout or something on this for primary cares, but I would
Boy, so it's coming, huh?
I would consider, if I were you, I would consider getting comfortable with low dose naltrexone
Okay.
and writing that sometimes. And
Okay.
not for everyone. This is not the cure all of every patient,
Okay.
because it's just not. But for fibromyalgia, there's decent data for it.
Mhm.
Kind of anybody with like poorly explained pain, it could be worth trying.
Okay.
And I've definitely written it, kind of generously in those patients. And then it's hit or miss.
Yeah.
But where I have really good results and probably two-thirds or more patients that respond in some positive way would be fibromyalgia, Ehlers-Danlos syndrome.
Right.
Um, and a lot of times when you're talking to those patients, the discussion I'll have with them around LDN includes like, hey, this is a medicine that probably regulates a dysregulated immune system a little. It's not going to fix your whole thing, but it probably regulates some of the over amped up stuff some.
Mhm.
It often helps with brain fog. It often helps with sleep. And so even though like I'm the pain specialist, I'm going to write it for pain and that's my intention. Like
Right.
it's not uncommon for that patient to come see me and follow up and be like, the pain is not that different, or well, we took the spikes off of it. It's the highs are not quite as crazy high, but what's really better is my brain fog, or what's really better is my sleep. Things like that, my energy maybe. And that's really what's been impactful for me of starting to write that medication. And it's a non-opioid.
Right.
At this point, you can get it. It's a compounded medicine, so patients need to pay out of pocket for it. But with the most cost-effective compounding pharmacies, you can get a prescription for maybe 90 pills that could last up to 90 days for like $50. And so suddenly that's not that different than your copay of, 15 a month on something with a regular prescription.
Nice. Certainly. Yeah, we'll definitely look into that. You see, you're giving
Yeah.
us free PME today.
Yeah.
So, naltrexone, right?
Mhm.
I cannot tell you how many patients come in with the combination of the pain, the brain fog, and sometimes you can't really localize the pain. Sometimes it's described as burning, they feel hot. It doesn't fit the traditional, what we studied in med school. So I can tell
Sure.
you that,
Yeah,
this
not
is
one
the
specific
diagnosis.
injury,
Yep,
clearly, that's yeah.
yep. So that's very helpful. Anything else for us?
Yeah, and I think looking for a target where you can, right, for that patient with back pain, like,
Okay.
if it's time to get an MRI, get an MRI. If it's, time to refer for a, joint eval from ortho or pain management, to do that, but I do think that like kind of getting to that next level of info if it's time. And I do think, continuing to counsel patients to, move more and be as active as possible is in spite of, challenges is a helpful thing for most patients. And again, there's times that we can't give that advice, but
Yeah.
overall, most Americans, most of us need to like move more.
Yeah. Yeah. Where do you see the future of pain management going? Is there
Ooh,
anything
that's
new
so
on
interesting.
the horizon? I know you talked about using the naltrexone.
Yeah, I think low-dose naltrexone is a real game changer in my practice. We also do ketamine infusions for pain in my practice, and we've had really exciting outcomes for patients, and often it helps mood and pain.
Okay.
But particularly for a couple of specific conditions. I mean, CRPS or complex regional pain syndrome is the thing that's been studied and is best understood for. That is the main thing that it has data for.
Sure.
Yeah, there are a lot of new technologies. There are a lot of new technologies coming in pain management, including some stimulation, like nerve stimulation, some temporary and some permanent.
Yeah.
Nerve stimulators have been around, or like the implanted spinal cord stimulators. Those have been
Right.
around, and they are often very good. But I think what's really interesting is this newer generation of temporary stimulators that sometimes will help keep pain from becoming like chronicified or, more embedded in the nervous system, that we can sometimes reverse, pain that's been going on for a period of time. And it may not always require a permanent implant. I mean, I think that's pretty interesting.
What about pain pumps? Do you do those at all?
I do. I do still work with those. I'm not, I think there's a lot of the most exciting research and technology is in the stimulator area more so than in the pump area. But
Okay.
we do still have patients who benefit from the pumps. The couple of folks that I'm working right now with pumps have had them maybe, trialed and implanted by someone else, but they need, someone to help manage it and or refill and or, adjust the medication. And we certainly do that in my practice.
So is the trend moving away from that now?
A bit, I think overall in the field, yes, I think there are still some doctors that do a high volume of them. And I think honestly, usually that's not a bad if you have a doctor, in your area who has a practice like that, I wouldn't tell you that's a bad idea. I mean, really, like those folks who have like a whole practice, like kind of geared to it, they often do a very good job of optimizing those pumps. I would say, again, in our practice, it's a smaller part and not our total focus. But sometimes, probably where the outlier excellent or, unanticipated or better outcomes are is probably in those practices where it's a big focus.
Got it. Got it. Dr. Merritt, this was so good. Thank you so
Oh, good.
much. Yeah. If we have some patients who would like to find you, they loved what they heard tonight, they're excited about, everything that they do. Can you tell us where we can find you or your practice?
Yeah, absolutely. Our website is lifestreamhealth.com, Lifestream health.com. And you can call us at 301-860-0305, and we'd love to talk to you.
Yeah. I have a lot of patients who are looking for awesome pain doctors, and I think Dr. Merritt is one high up on the list.
Do it.
But it was such a pleasure being with you tonight. I really appreciate your time. Guys, definitely check out. Are you on Any social media, Dr.
Yeah.
Merritt? Yeah.
I'm not doing a lot with it, but yeah, we have a practice Facebook page for
Okay.
sure. Feel free to find us there and practice Instagram too.
Okay, perfect. Guys, you heard her. You can go looking for Dr. Sarah Merritt. It's spelled Merrit, two T's, and you can find her there. Until next time, but thanking Dr. Merritt for being with us tonight. Take care, guys.
Thanks for spending time in the care room today with Dr. Cindy. If you liked what you heard, please subscribe, share this podcast. I'm also on Facebook and Instagram. You can follow me there. Remember, you're not alone in this. There are doctors who do care. The information in this podcast is for educational and informational purposes only. It is not a substitute for professional medical advice, treatment, or diagnosis. Always consult your personalized healthcare provider for medical guidance.